Thank you, everyone, for joining us today to look at the new research findings about mental health for people with intellectual disability. My name is Katrina Smith, and I am a lived experience researcher and a very passionate advocate for people with intellectual disability. I work as a project officer at UNSW, where I provide lived experience and input to research programs on mental health for people with intellectual disability at the National Center of Excellence in Intellectual Disability Health. We call it the Center for short. We will begin today with an acknowledgement of country. As the center, we respect the First Nations people and elders from this land. First Nations people have lived on this land for many years. Now we live, work, and play on this land together. We can learn a lot from all their stories and their knowledge. I would like to introduce you to your speakers for today's session. We are joined by Professor Julian Troller, the director of the center, Associate Professor Rebecca, the UNSW Chair of Intellectual Disability and Mental Health within this center, and Dr. Stefan Michalski, a research fellow at the center. Today we will be having a conversation about some new research that the center has published on mental health for people with intellectual disability. I am proud to have worked on mental health projects about understanding how many people with intellectual disability that have a mental health condition, the types of mental health conditions, why some people with intellectual disability are more likely to get mental illness, and to learn who needs more support to stay mentally well. I also worked on making the easy read version of the reports. I really enjoyed working on the projects because I could create stories and share my life experiences. This made me feel proud and confident and valued. I learned a lot through the projects, especially about being patient with myself and understanding my own timing and pacing. We will now speak to Rebecca, who will set the scene on mental health research. Rebecca, will you please do the honors if you can, please, by starting to tell us more about your role at the center.
Hi, Katrina. Yes, thank you so much. My role at the centre is as a clinician researcher. So I'm the chair of Intellectual Disability Mental Health, as you've mentioned, based within the 3DN team at UNSW Sydney. This particular role is funded by the New South Wales Ministry of Health Mental Health branch. I'm a psychiatrist who works clinically with people with intellectual disability and their families. And at the centre, I work closely with people with lived experience, their families, the government, and other peak bodies across the health and disability sectors. And together with other parts of our centre, including, for example, the Queensland Centre of Excellence in Intellectual Disability and Autism Health, and advocacy work by a range of our consortium members, such as the New South Wales Council for Intellectual Disability, Queenslanders with Disability Network, and Down Syndrome Australia, we focus on improving mental health outcomes for and together with people with intellectual disability through translational research, education and training, and advocacy.
Why is mental health for people with intellectual disability such an important focus for the centre?
It's a great question. And as we will soon hear from Julian and Stefan in more detail, mental health is such an important focus of the centre's work because people with intellectual disability experience much higher rates of mental illness across the lifespan. So in Australia, there are approximately 500,000 people living with intellectual disability, and up to around 3/4 will experience a mental illness at some point in their life. This is about double the rate of the general population and includes a wide range of conditions, including anxiety disorders, depression, psychosis, as well as a younger onset of age-related conditions such as dementia. And we'll hear more about this from Julian and Stefan shortly. Despite this higher level of need, people with intellectual disability face significant barriers within mental health systems, unfortunately. Presentations are more likely to be misunderstood or misattributed to the disability itself, meaning that conditions are often recognised late or only when someone's in crisis. This contributes to poorer outcomes, higher rates of emergency department and hospital admissions, and issues such as the overprescribing of psychotropic or mental health medicines. So for the centre, mental health is therefore a core equity issue. Our focus is on ensuring that people with intellectual disability can access timely, appropriate and high quality mental health care on the same basis as everybody else.
What do you see as the key challenges for or gaps in current research?
Although we are making great progress in understanding certain aspects, such as how common mental illness is in among people with intellectual disability, there are still several important gaps in the research. So first and foremost, I think we need greater inclusion of people with lived experience in all aspects of designing and conducting research. People with intellectual disability are still underrepresented as our research partners, not just as participants. And this would shape how questions are asked, what questions are asked, how outcomes are defined, and whether research actually leads us to any meaningful change. So this is a foundational gap, and we need to do better. Secondly, research is often done quite late or reactive, which unfortunately mirrors sometimes what we can see in our systems. We need much more work focused on prevention, on understanding what helps to keep people well, and on identifying early interventions when problems do emerge. A key part of this is developing better tools for things like screening, assessment, and measuring treatment outcomes in ways that are actually working for people with intellectual disability and accurately reflect experiences. The third issue I think about is that there are gaps between our systems, and I think this may be familiar to many people listening today. Mental health research often sits separately from disability, education, housing or justice research, but actually, as we know, mental health outcomes are shaped by whole of system factors, not just healthcare. And then the final thing I'll say is that there are still gaps in the translation. We need our research to directly inform service design, workforce training, and policy decisions. And the opportunity now, where the centre, I think, can play a leadership role, is to bring together this population level data that we'll hear about, clinical insights, and importantly, lived experience to move our field from describing the inequity to actively reducing it.
Thank you, Rebecca, for setting the scene so clearly and for outlining why this area of research matters and how it valued for me personally. Thank you. We will now move on to the Centre's recent research on mental health for people with intellectual disability. This work examined how common the mental health conditions are, who is most affected, and what this means for individuals, families, services, and policy. Will you do the honors, Julian? Can you please explain what questions for this research sets out to answer about the mental health of people with intellectual disability?
Thank you, Katrina. Thanks so much for hosting this podcast today. It's really exciting to share this research with everyone. I wanted to start just with acknowledging some of the funding that we received to do the research that made it possible and some of the help that we needed to make sure we had all of the information available to do the research. The funding for the studies came from lots of different places. The National Health and Medical Research Council, a Dementia Australia Research Fellowship for one of the authors, Dr. Svajic, from Down Syndrome Australia, and from the Aspen Foundation. And we needed lots of help to link the data we're going to talk about from the Centre for Health Record Linkage here in New South Wales and also from the Australian Institute of Health and Welfare. And without these types of support, this sort of research just wouldn't be possible. So we're really grateful. We also had a very big team doing the research, and I wanted to acknowledge all of the members of the team. We all worked together to use all of our skills to make sure that the research was done to the highest quality. And the two papers we're talking about today were published late last year in the Journal of the Royal Australian and New Zealand College of Psychiatrists. And we're very happy for people to have a look at the papers. We had two main research questions for the first paper. This was all about how common psychiatric conditions are in people with intellectual disability. So the study asks how common are those mental health conditions compared to the general population and how those rates of mental health conditions varied by things like age and sex and other situations for the person, and whether or not the patterns of prevalence have changed over time. And then the second paper that we looked at asked what factors increased the risk of developing a new onset mental illness or serious mental illness, such as psychosis or bipolar disorder for people with intellectual disability, and then also asked how the other aspects about the person, where they live, their age, their sex, their health, and other disability and developmental conditions and service-related factors might affect the likelihood of developing a mental illness. So those are the questions covered by both these studies. Over to you, Katrina.
Stefan, will you please do the honors? Can you please briefly explain how the research was carried out and why this approach was used to answer the research questions?
Thanks, Katrina. Yes, firstly, it was an honor to work on these projects, and It was a great opportunity to lead one of these studies that I'm going to talk about briefly. So look, to answer our research questions, we conducted 2 large population-based studies using linked administrative data from New South Wales. Our data team at the centre was able to link multiple existing data sets, and this included things like hospital admissions, emergency department records, community mental health services, Medicare data, and disability services data. And this linked data set that our data team created allowed us to follow people across different parts of the health and disability systems over time. So using our linked data meant we could study whole populations on a big scale. This is important because many people with intellectual disability can be missed in studies using clinic samples and surveys. So just to reiterate, so from our first study, which focused on prevalence, we compared around 100,000 people with intellectual disability with approximately 450,000 people without intellectual disability in New South Wales. And this group that we used to compare our sample was matched by age, sex, and geographic location. What this did was allow us to estimate how common mental health conditions are and to make fair comparisons to people without intellectual disability over a long 17-year observation period. So that was our first study. And our second study examined predictors of mental illness onset over time. So what we did was conduct a retrospective cohort study, and we followed people retrospectively, around 47,000 adolescents and adults with intellectual disability who had no recorded mental illness onset at the baseline period when they entered our study. We followed these participants, and what we did, we were able to examine when mental illness first occurred and which factors were associated with an increased risk of this mental illness over time. So this study, covering a nearly 15-year period of time, allowed us to examine when mental illness first occurred and which demographic, health, and service-related factors were associated with the increased risk. Together, this approach allowed us to estimate how common mental health conditions are for people with intellectual disability. We were also able to identify groups at higher risk and examine patterns that are difficult to capture in smaller or cross-sectional studies.
What does this research tell us about the scale of mental health conditions among people with intellectual disability?
Thank you, Katrina. Well, what we found was that both mental illness and serious mental illness was far more common in people with intellectual disability than the general population. About 3/4 of people with intellectual disability in our study had a mental health condition over the time we studied them. This was double the portion experienced by the general population, so it's really a significant finding. And then when we looked at other results, we saw that serious mental illness was 3 times as common in people with intellectual disability compared to the general population. So 16% of our group with intellectual disability had a serious mental illness compared to about 5% of the general population in the study. We also showed that serious mental illness seemed to start earlier and accumulate more rapidly in people with intellectual disability, especially for things like psychotic disorders. But we also saw that dementia had an earlier onset in people with intellectual disability and seemed to accelerate at a much greater rate with age. We saw that over time, it seemed to us that, like in the general population, the overall risk for mental illness went up. On the positive side, we saw that over time, there was some slight reduction in the proportion of people experiencing serious mental illness. So the two things were slightly different, two findings slightly different. We also found that for some conditions, the situations of people either raised or lowered risk of mental illness. And I'm going to leave that to Stefan to unpack next.
Were the findings about particular mental health conditions or groups that you would like to tell us more about?
Thanks, Katrina. Yes. Look, there was a few patterns that definitely stood out quite clearly. And what I'll do, I'll just briefly walk through some of these key findings, and it's probably a lot of information, but I will kind of briefly explain our key findings from that second follow-up study. And so what we found was nearly half of the cohort experienced the onset of a mental health condition during our follow-up period. The risk was highest earlier in the life course, indicating that many people had their first recorded mental health contact in adolescence or early adulthood. Specifically, people with ADHD or learning disorders were found to have the highest risk of developing both any mental illness and serious mental illness. Further, socioeconomic disadvantage was associated with increased risk of mental illness. Living in outer regional, remote, or very remote areas was also associated with higher risk of a serious mental illness onset. And further, physical health conditions were associated with the onset of any mental illness. And this kind of highlights an overlap between physical health and mental health needs, and the importance of kind of a holistic treatment approach, I guess. Further, what we found was male sex was associated with higher risk of serious mental illness. We also saw a lower recorded onset of both any mental illness and serious mental illness among people with Down syndrome and people with cerebral palsy. This likely reflects differences in service pathways or identification rather than absence of need. So overall, these findings show that risk is not evenly distributed and that some groups would benefit from earlier and more targeted support.
Julian, what are the key takeaways from this research for people with intellectual disability and their families, please?
This is a great question, Katrina. Thank you for asking it. Well, we know that not everybody will experience a mental health issue. That's really important to remember here. We know life has its ups and downs, but we must all, I think, prepare ourselves to have a good understanding of mental health and mental illness when things go wrong, so we can tell the difference between an understandable reaction to life's events compared to having a serious mental health issue. So I think that's really important for us to remember and to do. But given how common mental illness is in people with intellectual disability, it's important we take some key steps to build stronger resilience in communities, to build good networks of support, because we know that these protect against mental illness, as does exercise and other good healthy living, a good diet, a good lifestyle. And it's also important we take steps to build our knowledge and skills about how the mental health system works, even when to get help and how to access help at different stages of life and different stages of a mental health journey. Another takeaway message is that there are some situations where mental health seems to be particularly at risk. For example, Stefan spoke about when a person with intellectual disability also has other conditions such as ADHD or another learning disorder or more complicated physical health issues. And so we need to be aware and alert, but are not alarmed in situations where those things come together. This makes really good management of those other conditions very important, because the better the management of those conditions, the more positive the mental health outcome for the person. I think particularly powerful for me is the idea that if you live in somewhere other than a major metropolitan area, so regional, remote area, or a place where services are thin on the ground, making sure if you've worked out how to access services in your area is really important, because you may need them at some point. So I think discussing a plan with your GP or practice nurse ahead of any problem and having that action plan documented so that you know what to do in a situation, how to access services is really important. And so I think also we've learned a lot that advocacy is a really powerful tool to change the situation. So there's much better mental health services for people with intellectual disability than when I was a younger doctor. And so to me, it also highlights the importance of people with intellectual disability and family members in advocacy for better mental health supports in your area or on a bigger scale, that advocacy has been really powerful. So if there's an opportunity for you to get involved, please do so.
Rebecca, will you please do the honors of saying what does this research mean for health professionals who work with people with intellectual disability?
Another excellent question. Thank you, Katrina. So I think my take on is that for health professionals, this research is a clear call to think proactively about mental health when working with people with intellectual disability. So the research has shown us that mental illness in people with intellectual disability is common. It often begins early and is influenced by lots of interacting factors. So things like co-occurring health conditions, service transitions, life stressors, and so on. So for health professionals, if someone is presenting to your service with a particular concern or behavior that might be different or out of character for that individual, amongst other causes such as, say, physical health conditions, it's actually really important for us as clinicians to be asking ourselves, could mental illness be a possible factor here? I think the research also reinforces the importance of proactive mental health surveillance. So we need to routinely be asking about emotional well-being, behavior change, and other features such as sleep or stress, and doing so in ways that are accessible and inclusive of the individual and their families or supports. I think the research also challenges the idea that mental illness is somehow inevitable or simply part of the intellectual disability. Many of the identified predictors that we've heard about today relate to modifiable factors. So that tells us that there's actually real opportunity for prevention and early intervention. And for us as professionals, this means working across a range of sectors, and that means collaborating with disability services, primary care, education sector, housing, justice, and so on, rather than seeing mental health in isolation. And finally, the research highlights, I guess, an opportunity for us to reflect on our own practice and the value of our own education and training, particularly when it comes to more inclusive models of care, so that mental health support is not an exception for people with intellectual disability, but is actually an expected and routine part of any good healthcare. So thanks, Katrina. Back to you.
Julian, will you please do the honors of saying what needs to change to improve mental health care for people with intellectual disability in Australia?
Thanks, Katrina. I was nodding furiously when Rebecca was talking because I'm in agreement with all of her excellent points. And we're coming toward the back end of the webinar now. So I wanted to take a bit of a step back and look at the bigger picture, because I think this is really important. Thinking about what does the research say about that bigger picture and what services should look like and how we can get there. And I think it's important we acknowledge first up that service provision in mental health for people with intellectual disability across Australia remains quite patchy and inadequate in many places. And many mainstream services are not yet able to meet the needs of people with intellectual disability. So I acknowledge the big gap. So this makes it really important that at the top level, we think, how do we embed the mental health needs of people with intellectual disability into national health planning and service design? And I know that's something that people on this webinar are really passionate about and are working hard to achieve. And certainly the centre will be working hard to make sure that happens. Rebecca mentioned the social determinants of health. And it's important that we start to think more broadly, not just about looking at these outcomes that we've heard about today, but taking that step back and thinking, what are the important things we need to change in our society and in our supports for people to relieve poverty, to relieve isolation, to reduce trauma and the impact of these social determinants on mental health. And again, that comes down to really good policy and its implementation, but it also really comes down to how we include people in society with disability. Another important aspect, I think, is making sure that we have adequate specialist capacity in both public and private mental health services. And those of you who have accessed services know that things can be really thin on the ground in many places. We argue really strongly and have done over time that really this workforce should be funded proportionate to need. And we know that there's underinvestment, so we're arguing for better investment in intellectual disability mental health care. And to do the job well, of course, then we need a skilled and experienced team and workforce. And we need suitably streamlined services and pathways within those services for people with intellectual disability to make sure that the experience of people with intellectual disability accessing services is improved. One of the things working with big data sets has taught us is that data systems are really important. And so we're working hard with health departments and data systems to make sure that people with intellectual disability can be accurately identified in our systems data, and that their outcomes, particularly in the area of mental health, can be reported regularly, and that we can keep track of whether we're closing the gap compared to the general population. Of course, importantly, we know that the Disability Royal Commission made a series of recommendations that were relevant to healthcare and mental health care. And we need to make sure that governments and services and policymakers are held to account to implement those findings, because they were based largely on the experience of people with disability sharing what they'd experience in terms of lack of access to services, including in the mental health system. Of course, I think we also need to bear in mind complexity. So better recognition and targeted support for people with a level of complexity, an additional condition, such as a learning disorder or ADHD or another developmental syndrome that places a person at risk, is a really important part of the strategy. There are some other actions we think the results of the research highlight. Having a good multidisciplinary mental health team is really important. We know from the way systems work that this better meets people's needs. Expanding things like telehealth and step care models so that services are more accessible and available where people need them, particularly in disadvantaged or remote communities. We know that we need to boost the capacity and number of things like specialist intellectual disability, mental health and health teams. In some places that's occurring quite rapidly, but in others it awaits development. We also need to measure the impact of those more specialised services well, so we can demonstrate their benefit to lives. We talked a little bit about improving workforce expertise. Both Rebecca and I are really passionate of working very closely with a group that is trying to develop specialised training for psychiatrists and future psychiatrists with the Royal Australian and New Zealand College of Psychiatrists. And of course, improving early identification. I think Rebecca touched on this point, but making sure we've got the tools to screen and give targeted intervention and help, mental health help for people with intellectual disability, including those high-risk groups, is really, really important. So, overall, I think there's so much more to be done. Progress has been made, but we're calling for long-term, system-wide structural change and not just isolated programs. I think we all have a responsibility and a role to play, as I've said, from people with intellectual disability and families and carers, in advocacy, people like ourselves understanding what the data says about the experiences and outcomes, and I think clinicians and health regulatory bodies and lead and peak bodies all have a role to play. So we look forward to working with many different groups to try and further improve the mental health services system for people with intellectual disability.
Thank you very much to Dillian, Stefan, and Rebecca for sharing your knowledge and taking the time to talk with us today. I really do appreciate how you explain the research in ways that connect to the real lives and real experiences. It is important that mental health research is not just about the numbers, but about people with intellectual disability and what support we need to live well. Thank you very much for recognizing the value of lived experience and for working alongside people with intellectual disability in this research. That makes the work stronger and more meaningful. Thank you very much to everyone who joined us today. It was amazing to hear you all personally. I hope you take away a better understanding of mental health for people with intellectual disability and why early support, good services, and inclusive research really does matter. On behalf of the Center, thank you so much for listening, learning, and being part of this conversation. So thank you so much. We look forward to continuing this work together.